Good afternoon and welcome. My name is Meg Beyer. I am part of the Managed Care Technical Assistance Center, or MCTAC team. I'm here today joined by many of our partners from the Office of Mental Health who are going to walk us through our content for today's webinar. So I want to thank you all for joining us again. Just a few logistics before we get started today. So today's webinar is being recorded. The recording along with the slides are going to be distributed to everyone who joined. So stay tuned for those. It does take a bit more time, like 24 hours for us to be able to download the recording, but we hope to be able to share this with you soon. The other thing today is that we are going to be having time set aside at the end to collect questions and try and answer some of these questions on the webinar. So what we're asking everyone to do is to use the chat box functionality that can be found on the right-hand side of your screen. You'll see it says chat, and to enter your questions there and submit them to all panelists. That way, any of the presenters can see the questions. MCTAC is going to be collecting all these questions, and we'll be reading them aloud so that all of our state partners can hear the questions and then address them if possible. So I just want to remind you that throughout the course of the entire webinar, please don't hesitate to chat in your questions. We'll be collecting them the entire time. So with that, I want to ask Maura to go right ahead and take us away. Maura?
All right, thank you. Thank you very much. First, welcome everyone to this webinar. We're very glad that we're able to be here with you today. And I want to start out with saying thank you. Thank you for the work that you're doing. We know that you are facing many challenges. Your challenges are great, and we want to recognize that. We know that you're faced with 24/7 staffing issues with individuals with high needs who are testing positive, both your staff and the consumers you're providing services to. We know that you're short-staffed and short with the PPE equipment. I want to assure you that we are trying our best to address those challenges that you have, both with flexible billing as well as flexible regulations and attempting to secure some PPE for all of you. Again, thank you for your partnership. As this virus moves throughout the state, we believe some of your challenges will grow. And we are working with the epicenter right now in New York City, and from there learning how we are going to be able to respond with the Article 28s in our state hospitals, as well as our community partners through the coming weeks. I want to share some good news, and that is that we did have an executive order tying to the background checks and fingerprints. Our attorneys are working on that right now to get you guidance out on that. Also, we have put together a bundled request for PPE, and you should all know that we're also working with both SHINE and ACL, having conversations about your continued needs, and we will meet with them twice a week starting this week to make sure that we are on top of what your needs are. So today we're going to have a number of presenters. Dr. Kasoy, who's our medical director for OMH's special projects. Donna Bradbury, who's the Associate Commissioner for the Division of Integrated Community Services for Children and Families, and Brett Hebner, who is our Director of Housing. The topics that we're going to be covering today will be the general COVID-19 information, infection control, operations during the emergency, both staffing and individuals we serve with symptoms, maintaining continuity of operations and care, and our program and state aid flexibility. At the end, we would certainly welcome any and all questions that you have. We will do our best to answer them on this webinar. If we cannot answer them, we will get the answers for you, and we will put it in our FAQ. Again, as I turn this over to Donna Bradbury, I want to say thank you, and we will continue to work with you. We want your feedback, and we want to know what your needs are. Donna? Donna Bradbury?
Thank you, Moira. Sorry, I was having trouble getting off of mute, but thank you very much. And thank you all for joining us on this WebEx this afternoon. And I'd like to echo what Moira just said, acknowledging the challenges that providers are facing right now, with a particular shout out to children's providers. Thank you for addressing the needs of the most vulnerable children and families in the state, and we hope that the information we present to you today is helpful. So a few words about children's residential and site-based programs. I want to make all attendees today aware of the fact that the guidance that's going to be presented to you during this webinar is applicable to all children's residential and site-based programs. We will be issuing additional OMH guidance specific to children's site-based mental health programs soon in the coming days. In the meantime, the OMH guidance that's been issued for infection control is applicable to crisis residents serving children and youth, community residences for children and youth, and residential treatment facilities. I also want to note that OMH is aware of the unique challenges that children's providers face. I want to mention two specifically that we are in the process of working on and trying to find solutions to. The first one is that we realize that discharges from OMH children's residential programming are dependent upon school placement, and we're working together with state education to generate solutions to the problems that are before us, given the fact that districts are closed and committees on special education are not meeting. The second issue I want to make note of is related to those providers who have campuses that involve that include both OCFS and OMH programming, and we're actually actively engaged right now with at least one provider who is experiencing a situation in which children are symptomatic and they're needing to be flexible with space, and where they may be wanting to relocate children from, for example, OCFS licensed space to OMH licensed space, and we're actively engaged in finding solutions to that and working with our council and licensing staff to understand exactly how much flexibility we can have given that scenario, and also allowing some, hopefully we'll be able to allow some flexibility in terms of staff that are typically allocated to one licensed program or another, perhaps being able to share time. So stay tuned on that. We are working very hard to provide as much flexibility as possible. So with that, I'm going to turn it over to Dr. Kazoy, who's going to talk about COVID-19 and infection control. Thank you.
All right. Thank you, Donna. Thank you, Moira. Thank you to the folks at MCTAC. And most importantly, thank you to all of you who are at the front lines in our residential programs, taking care of, some of the sickest and most vulnerable and, neediest New Yorkers out there. You, along with the nurses in the hospitals and outpatient programs, first responders really are, you're the heroes in all this. And I see you all no different than I would, the first responders are 9/11, or soldiers who take, who are the line of defense for civilians in a war situation. This really is a crisis that we haven't seen in a really long time in our state. And everyone is really sort of stepping up and doing what they can in some really difficult situations. And I'm really thankful to all of you for that. Just want to get into some of the biology of this virus, and just to sort of, make sure that everyone's on the same page about what to expect here. So COVID-19 is a virus that in time will spread to the majority of the population. And it's dynamic, its spread is going to be similar in many ways to what we expect with the common cold. However, this virus is it sort of causes an illness that is a lot more serious than the common cold. So the goal now, right, isn't to stop the spread, because that's not possible. The goal is to slow the spread as much as possible to allow our hospitals, our Article 28 general hospitals, time to increase their capacity to take care of everyone who needs to be hospitalized because of this virus. So that's the idea. So you know, the recommendations for everyone to kind of stay at home, to physical distance, and so forth is all about that, so that the rate at which people get sick is slow enough that, you know, folks are getting better and opening up beds in the hospital in time for the next person who gets sick. So we expect over time a majority of New Yorkers to become infected and you know, experience this. However, you know, based on what we know today, and these numbers, you know, I crunched over the weekend, about 14% of people who get infected need to be in the hospital. And only 4% need to go into the intensive care unit. Now, these are those beds with the famous ventilators that you're hearing about in the news. The death rate, as published right now, is about 1%. However, the real numbers, the true numbers, are probably lower than this, since testing is not generally available, and we're primarily testing people who are, you know, exposed or known to be sick. And we know that there's a lot of people who sort of become infected and never develop symptoms, or who only develop mild symptoms. So even though we are in a really intense time now, working really hard to make sure that we are sort of clearing the hospitals, allowing the hospitals to build up capacity, we know that most people are going to recover. Most people are going to bounce back. And we also know that when people do go to the hospital, most people get discharged from the hospital still with some symptoms. So people don't stay in the hospital until they're all the way better. They stay until they are better enough so that they can sort of continue to recover at home and open up that hospital bed for someone else. And this is all happening, you know, in a way, the country was caught flat-footed. There's a national shortage of medical supplies, protective equipment, ventilators. And this makes it more difficult to slow the spread, but it doesn't make it impossible to slow the spread. So, you know, our task, the task of every single person living in the state, is to do what they can in the context that they can. And the more that we slow it, the better off we'll all be. We can move to the next slide, please. Okay, so let's talk about the symptoms of COVID-19 illness. For the most part, most common symptoms are a new fever over 100.4 degrees Fahrenheit or 38 degrees centigrade. Fevers in this illness come and go. It's not kind of like a continuous fever, and then when it goes away, you know that you're better. Not quite. What we're seeing is going up and down. The temperature goes up and down. So that's normal and expected in this illness. A new cough, new sore throat, new difficulty breathing. Those are the common sort of signs of COVID-19. People might also get sort of belly problems, is diarrhea and so forth, but that's less common. The most common is fever and respiratory issues. How is COVID-19 spread? COVID-19 is spread primarily through the little spit droplets that happen when people cough or sneeze. So the biggest recommendation to sort of stay 6 feet away from others is to avoid getting coughed or sneezed on, because then those little droplets fly through the air and land on your nose or your mouth, and then you become infected. It's kind of gross, but that's mostly how this infection gets transmitted. A secondary way, less common, but also possible, is someone coughs or sneezes or touches with an infected hand a doorknob or a desk or a sink or a counter, and then someone else comes by, touches that same space, and then touches their face. And therefore, the virus gets in their nose or mouth, and they get infected. So the way to reduce the spread here is to do everything possible to prevent the spread of droplets, prevent the spread of these little spit drops that are in the air or on surfaces. And we do that by staying physically distant and by frequently washing our hands, by avoiding to touch our faces, and by sort of cleaning surfaces more frequently. We can go to the next slide. So just some basics of infection control. So on the OMH guidance website, which Brett will show you, shortly, you'll see a pretty lengthy infection control guide for residential treatment programs. Take a look. It's a lot more detailed than this presentation, and we will likely be updating it. So keep an eye open for that. Educate as much as possible your clients on the importance of hand hygiene, not touching your face, and physical distancing. The more that people understand that if they do this, it'll be protective for them, the slower this will spread. Now, some clients might have really difficulty with this because of their psychiatric symptoms or their cognitive symptoms. And the time to start working with the outpatient providers, or psychiatrist or primary care doctor, to get help on how to mitigate, or prepare for these particular clients that you've identified who might have difficulty with this is now. Be proactive before people get sick, and do your best to see if you can sort of bring more resources on board to help clients that you've identified might have more difficulty with this become more compliant. The New York State Department of Health has some great posters that you should post around your facilities. They're translated to different languages if you need it. The link is on this guidance that I mentioned just now. Make sure that you do everything possible to keep visitors out of your programs. Unless the visitor is necessary for the residents' health and well-being, try to limit the number of people who are coming indoors to your programs. And if someone is sick, if someone has coughing, sneezing, symptomatic in any way, definitely they should not be coming in. This might be a change, right? People are used to socializing, but it's really important that we try to keep sort of home units, separate from other home units as much as possible. Big time, especially, think about this if you're a family care operator. Try to keep, your home unit separate from other home units. This might be a big change from what's been done before. However you're disinfecting, however you're cleaning your facilities now, your homes now, continue to do the same, but just do it more frequently, and focus especially on frequently touched locations, tables, doorknobs, light switches, the toilet flushy handle thingy, sinks, if people have smartphones, if there's a telephone at home, the telephone handle, the mouse of a computer and so forth. Things that people touch frequently should get wiped down more frequently, at least daily. Work to connect with outpatient providers via telemedicine. The Office of Civil Rights in the federal government has waived HIPAA enforcement for the duration of this emergency. So you can use FaceTime, you can use Skype, you can use any real sort of video connection that is available on smartphones or tablets to connect with outpatient providers. The Office of Mental Health has also waived the requirements that it even be visual. And you can have telephonic connection with the outpatient providers, and try to do that as possible instead of an on-site visit, unless the person needs an injection. If the person needs an injection, you can't give an injection over video. Talk to your staff and your clients to report symptoms as soon as possible. The sooner that you know, the sooner that you can begin to make plans to sort of keep people apart and separate folks. If your facility has shared bedrooms, try to keep the beds at least 6 feet apart and try to have folks sleep in a head-to-toe configuration to maximize the distance between people's mouths. So if they're coughing, it makes it harder for those droplets to travel to the other person's head. Next slide, please. Talking, about staff. So if a staff person has symptoms or tests positives, they should stay at home until they've been without any symptoms for at least 3 days without the use of any medications to help the symptoms get better, or 7 days from the moment that they first test positive or first get symptoms, whichever one is longest. So if staff is sick, they should not come in because that will help spread the infection. If a staff person has had a direct and extended contact with someone who tests positive or has been sick with something that looks like COVID-19, and they have no symptoms, they can continue to come to work provided they wear a regular surgical mask, a paper mask, and they should check their temperature every 12 hours and go home immediately if they develop respiratory symptoms or fever. So this way, even if your staff has a direct contact, they can continue to come to work and help take care of your clients. A direct and extended contact is sort of being in a room with a person who's positive for an extended period of time, like a delivery or walking by or a quick contact doesn't count. A contact of a contact doesn't count. It's just a direct extended contact. If a mask is not available, then that staff member should probably stay away for 14 days until after the very last exposure. They should quarantine themselves like the general population. They should also be very careful about not exposing their family members, and they should be instructed about that. It's very difficult. My husband is a physician in an emergency room here in the city. He definitely has had direct and extended contact, but we live in a New York City little apartment, so it's very difficult to stay, to do so complete physical distancing because of where we live. So we do our best, and people should do what they can, the best they can. And the idea is to slow as much as possible, make it as difficult as possible for the virus. But we understand that, in healthcare settings, it's just more difficult. Next slide, please. We encourage you to the degree that you can to continue to accept new referrals. And the reason is that we're trying the best we can to make room in the hospitals. A lot of the hospitals are going to convert their psychiatric footprint into COVID units, and the more capacity the hospitals have, the better it'll be for everyone. The programs, though, you all have the right to request an attestation or a note from the referrer that the client does not have any new COVID-19 symptoms, any recent symptoms. You can't ask for a negative test because testing is just not widely available. We wish that there was sufficient testing capacity in the country, in the state, but there isn't. The testing is being reserved for folks who are quite ill right now. If possible, any new clients should have their own room. They should really be encouraged to maintain physical distance. And if masks are available, they should wear a mask for the first 14 days. And if the mask is not available because there is a PPE shortage, then, really encourage that social isolation, that physical isolation. Don't socially isolate them, talk to them, but try to do it from 6 feet distance. Next slide, please. Okay, but when someone develops symptoms, and this is going to sort of spread throughout society, the person with symptoms should be asked to stay in their room, ideally assigned to a single room. And if they had a roommate, that roommate ideally should also have their own room for 14 days. And if that roommate has no symptoms for 14, after 14 days, they can go back to sharing a room with someone else. Um, the client who has symptoms should take meals in the room, and if possible, if available, that client should wear a mask. And the purpose of wearing a mask is when you cough or when you sneeze, the little droplets get trapped in the mask, for a large part, and they don't spread all over. Once someone begins to develop symptoms, immediately contact the local health department for information on whether testing is available. And then local health departments may have different provisions for alternative housing arrangements, but that's going to depend county to county, local health department to local health department. It's going to depend. Most cases of people who get sick will not need to be hospitalized, as I said before. A hospitalization is necessary for someone with sort of breathing difficulties or who just seems to be sort of too sick to be, in a kind of a residential setting. If it looks worse than a bad flu, then you call the hospital, see what the situation is at the hospital, and really consider sending them. The hospital might say, you know what, they're not sick enough to be admitted, and send them back, and that's something to be expected. The hospital might say, yeah, they are pretty sick, we're going to keep them in the hospital. That also can happen. If more than one client is positive, then those individuals can share a room if there's shared bedrooms in the program. And this is a really good time to get all your clients who smoke on nicotine replacement therapy. Get them on the patch, on the gum, or the lozenge, or the nasal spray, or the inhaler. Give them as much nicotine as they want, even if they don't want to quit smoking. Talk to the outpatient provider, because the more that you can prevent folks walking back and forth to outside to go smoke, the less exposure everyone has. So NRT is definitely appropriate right now to help reduce that craving, to help clients sort of comply with isolation. Next slide, please. So if when someone develops symptoms in your residence, your other clients who are 50 or older, have kind of medical problems, or who smoke, should wear masks if they're available. If masks are not available, definitely to emphasize the importance of physical distancing and increasing hand hygiene and avoiding touching their face. Individuals who are older or have medical problems or who smoke, are at higher risk of having to go into the hospital than younger folks or healthier folks or folks who don't smoke. Staff should begin to increase their hand hygiene and sort of implement more strict physical distancing and wear masks if available. Increase the frequency of wiping down surfaces. If you have several bathroom facilities, set one aside for people who are symptomatic or positive. Continue to wash those surfaces. Leave the windows open to ventilate. You leave the fans on, but try to sort of cohort people who are symptomatic to a particular bathroom facility, if possible. If you only have one bathroom, then it's really important to wash down those surfaces, to disinfect as much as possible. Leave the fans on. If there's windows, leave the windows open. After someone who's symptomatic showers, let all that steam clear. If someone who's symptomatic needs to use the bathroom, and masks are available, have them use a mask, unless, of course, they're showering. Try to stagger shower time so not everyone is showering in the morning or the evening. And for the folks who are not symptomatic or haven't tested positive, leave time in between showers. Fans running in between, if you can, leave the windows open to clear out those little spit droplets. Just to reiterate, clients with symptoms should not use shared spaces. Programs may have to change existing routines to accommodate. So figuring out how to get snacks and so forth. It's okay for them to go outside. They should just stay 6 feet away from everyone else. As the weather gets nicer, you might encourage people to spend more time outside, more fresh air, more ventilation. Next slide, please. Our folks, do get medically or psychiatrically hospitalized for different reasons, and they do get discharged. And when they come back from the hospital, even if they were hospitalized for a reason other than COVID-19, they may have been exposed to the virus in the hospital. So when these folks come back, sort of treat them as kind of like a new client, try to keep them more isolated as possible, emphasize the importance of physical distancing, address their anxieties and fears, answer their questions, and do the best you can to sort of monitor them for those first 14 days. If they never develop symptoms, great, you're in the clear, and then you can go back to the prior routine. For folks who come back from the hospital because they were admitted with respiratory or other, COVID-19 symptoms, they will probably be coming back before they're all the way better, in which case treat them like you would an individual who, gets sick and doesn't need to go to the hospital. Just, keep them more socially or more physically distant from others, address their needs, anxieties. This is a very difficult thing for clients. Just work with them through it. It's a very difficult situation, and your staff may need extra support, extra emotional supervision on sort of managing this. Next slide, please. Okay, just a few words on scattered site housing. So again, educate the clients about the importance of not socializing indoors with others, restricting visitors, hand hygiene, not touching their face, basic cleaning, when they're out and about in public, staying 6 feet away from everyone else. It really has to be a case-by-case decision whether the agency continues to visit those clients. The reason to continue is if not visiting them face-to-face in person would lead to a decompensation. Do they need help with basic living needs? Is there a risk of disengagement or sort of a psychiatric hospitalization if they're not visited? So if there's a risk, then probably it's worth to continue to see them. But if not, maybe you can get by with telephonic or video visits if possible. And when a staff goes to visit them, they should, employ good hand hygiene before they come in, after they leave, and if available, wear a mask. If not available, stay 6 feet away to reduce the risk of, the staff coughing on the client or the client coughing on the staff. So I went through a lot really fast. And there's definitely happy to clarify or answer any other questions in the question period that's coming up. I now want to pass the baton on to Brett Hebner, who's OMH's Director of Housing.
Thank you so much, Dr. Kasoy. Good afternoon, everyone. I just want to reiterate what other folks have shared in terms of just being so thankful to you and wanting to support you in any way we can. We're working hard to do that, and we just want you to know that we share your concern for your staff and your residents. Hopefully this guidance is helpful, and we'll continue to update as much as possible. So I'm going to basically review a few of the issues that have come to our attention, and then we'll turn over to turn over to a time of questions and answers. So the first issue that we want to make sure that we're perfectly clear on is that in terms of continuity of operations, the Executive Order 202, which is what folks would commonly refer to as the stay-at-home order, where that outlined what essential and non-essential businesses are, definitely includes any agencies that are operated, licensed, designated, funded or authorized by OMH. They're all considered essential, and this includes your administrative staff and offices. Those employees are necessary to support the essential functions of your agency's mission, and so they're certainly included. We want to be unequivocal about that. Providers' leadership should use their judgment, however, on how to balance achieving those achieving reduced close contact in offices while maintaining operations. So those functions such as payroll and those things that could potentially be done remotely should be done to the extent possible. Next slide, please. Again, to reiterate something Dr. Gasoy indicated, that we're asking that wherever possible, housing providers continue to accept admissions. The ultimate goal here is to up the chain, allow hospital beds to be freed up for medical needs rather than for psychiatric needs, in order to treat those who are in the physical hospitals themselves who are needing COVID-19 hospitalization. However, we recognize that the difficulties that you're facing. So if you anticipate experiencing, sorry, the chats are interrupting my slide here. Experiencing any interruptions or program operations or modifying program operations, please notify your field office and the local government unit. Next slide, please. As Moira indicated at the beginning of the slide presentation, this slide is a bit out of date in that we were working with the Governor's Office and Justice Center. That there has been an update to the executive order I referenced. It's 202.13 that does provide some flexibility around staffing and fingerprinting, et cetera. However, we're currently working on guidance and hope to get that out as soon as possible. That basically interprets that executive order. So hopefully we'll be able to get you some more guidance and flexibility with regard to keeping your facility staffed. Next slide, please. Again, we totally recognize the challenges that you're facing keeping your facility staffed, and we would consider proposals of modifications to staffing patterns to ensure basic needs of our service recipients are met. So to the extent that you're wishing to propose those kind of changes, we're again asking that you submit, contact your field office, submit, a summary of what you're proposing. We'll review and respond with either questions or approval, and hopefully turn that around in an expedited manner, hopefully one business day. And the underlying understanding here is that providers must continue to make every reasonable effort to ensure resident health and safety in the provision of basic necessities like food, medication, etc. Next, please. Similarly, I'm not sure if folks were able to watch Amos Lane, our CFO's presentation, our webinar last week, where they described the flexibility on the state aid side. We just want to reiterate that here. So similar to the process for programmatic adjustments and modifications that you may be proposing on the state aid side, we're open to providers submitting waiver requests, again, to their field office and their LGU around flexibility within budget categories of service utilization, et cetera. So we'll again attempt to review and respond with approval or request additional information on an expedited basis, hopefully within one business day. Next, please. So another question that came up prior to this webinar was around the idea of using vacancies in programs, if possible, to isolate individuals. And we would encourage you to do that if that's possible. And again, a similar question around trying to isolate people through temporary housing arrangements in areas that may not be currently occupied by housing within your buildings. That's obviously a case-by-case basis and may be acceptable, but we need that sleeping area to be finished, have emergency egress, have all of the safety features that we would expect in any normal circumstance, so that we're not sacrificing one element of safety to achieve another. So I think I'll, next slide, please. I think I'll turn this back over to Moira. Just want to point out that all of our guidance is regularly being updated, and we've tried to keep it in one centralized location there on the screen on our website, and we would encourage you to review that, and we're happy to entertain your questions at this point.
Thank you, Brett, and others. We would like to open it up to questions now, and we will, as I said earlier, do our best to answer those questions. If we cannot answer those questions, we will take it from here and we will put them on an FAQ.
Okay, thank you, Moira. And thank you everyone who presented just now. We did get a whole bunch of questions that came in. So I'm just going to start. If we're able to answer, fabulous. If not, we will put them in the parking lot and send them off to the state and figure out how to address them later on. So our first question, oh, great. Thanks, Moira. The first question is, if the individual is discharged with COVID-19 symptoms, are they still considered contagious?
Dr. Kasoy, can you answer that?
Yeah, so if anyone who's having symptoms, you know, are still in that period that they might be spreading the virus. In fact, you can have what's also known as asymptomatic carriers, where they're infected, they're spreading the virus, but they don't show any symptoms. So when someone is discharged back to the residence with COVID-like symptoms after they were hospitalized, they really should think about like how to maintain those 6 feet distance if available, have them wear a mask, increase that sort of wiping down surfaces and so forth, and educate everyone to sort of employ good hand hygiene. But yes, they can still be in fact sort of contagious when they're discharged from the hospital.
Thank you, Dr. Kasoy.
Great. Thank you. Our next question. So this provider is asking, since we monitor medications, is there going to be a waiver to allow for staff to fill pill trays on behalf of clients during the pandemic? The concern is the lack of availability for PPEs, masks specifically.
So let me make sure I understand that question. So you're asking if individuals who generally pour their own medication because we supervise that medication, can staff now actually fill the pill boxes? Is that what you said?
That's what the question looks like. Yeah.
Okay, that was the question. I will have to take that to talk to folks here in regulation. I don't know the answer to that question. It is not this first time we've heard that question, and we will get back to folks on it.
Okay, great. We'll parking lot that for the moment. Thank you for that question.
Yep. Good question.
Next one. Yeah, exactly. All right, this individual is concerned about how 14 days isolated in a room may affect our SPMI clients. Are there any exceptions for residents to be able to leave the room?
Oh, yes. You don't have to stay isolated in the same room. You can go outside. What we encourage is not for that individual not to be in like a shared kitchen or shared living room. When they're in the house, the idea, we would really encourage for people who are quarantined to be in a room to reduce the risk of spread. But it doesn't mean they can't go outside. If they do go outside, we also encourage that they stay 6 feet away from other folks. But yes, I mean, I also, would go absolutely bananas if I had to just sort of stay in my apartment, in my room for 14 days. But you can go outside.
Thank you. This is another question that we have. So this provider is asking, what if they do not have single bedrooms in a community residence?
That's a good question. So if you don't have single bedrooms, you have a lot of limitations in terms of physical distancing, right? So within the bedroom, I would encourage keeping the beds as much as possible at least 6 feet apart, have a sleeping arrangement of, toe to face, so that you maximize the distance between people's heads. And I think programs have to do the best they can, right? The best they can. So if it's just not possible for people to have single rooms, then it's not possible. And we are part of a collective, right? So we're encouraging all of society to do this. In our particular situation, as long as we do the best we can, that's the best we can to slow the virus. And really that's all that's expected. And as long as everyone else, does whatever they can, we'll work to get the hospitals up to speed, to increase the capacity. But there's no expectation that residential programs are going to do more than is possible, right? If single rooms aren't possible, then single rooms aren't possible. You have to do what you can in the situation that we're in, and that is totally understandable.
Thank you for that. So I got a question, actually. So someone asked about the PowerPoint today and the recording. I can confirm that they are both going to be available to everyone, probably within 24 to 48 hours. So we will be distributing an email with links to the slides as well as the recording of this webinar that we're on at the moment. So if you'd like to share that with your colleagues and staff, stay tuned. That'll be coming shortly. All right, next question. Let's see here. What are the state's thoughts or recommendations on restorative services and ability to bill if the individual chooses to self-quarantine with their family?
Well, one of the ways that you can continue to do your restorative services is via telehealth means. So you can call that individual and still work with that person over the phone and bill for that. There is guidance out there for telemedicine, and it is on our website. Additionally, just along those same lines, was asked us recently, well, what if the person just wants to stay in their room and they're in quarantine? The same thing can be done. You can talk to them via the telephone and provide that service and bill for it.
Great. Thank you, Moira. All right. Our next question. So must non-sleeping areas that fulfill the criteria described also have doors to be considered acceptable alternatives, or may other options such as privacy screens be considered?
Are you talking about for quarantine areas?
Or alternative rooms?
I'm going to ask the person who chatted this question. I could make a guess, but I'm not entirely sure. So I'm asking whomever chatted this question in, if you could clarify, and I will come back to this question next. So if you can clarify if that's okay. Yeah. So if the person who asked the question could just clarify particularly what you're referring to, that would help us get to the answer. And I'll come back, I promise. Let's see. So I think someone's asking a question about dates on the FAQ guidance, when information is added or updated. And I believe, correct me if I'm wrong, OMH partners, that once the guidance on the OMH guidance page is updated, there's usually a date placed next to the link on the date that's been updated as of. At least that's how I've been seeing it when I visit the website.
Yeah, that's true. We're updating it both on the document and and next to the link.
Thank you, Ben.
Thank you so much. Yep, thank you. Let's see. Can Dr. Kasoy repeat how long he recommends staff stay home if they are symptomatic?
Sure. So if someone gets sick, tests positive, or has symptoms consistent with COVID, they should not come back to work until they've been totally symptom-free without the use of medications for 3 days, or 7 days since they first tested positive or first had their symptom, whichever is longest. And this is something that we can put in the FAQ also, just so that everyone has. And it's the same recommendation that's posted on the CDC website and the Department of Health website. And if this gets updated by our state or federal partners, we'll be updating this.
Got it. Thank you for that.
Yeah.
I do have clarification about our previous question. So it looks like if we need to separate people for the purpose of quarantine, may we designate a non-sleeping area for sleeping temporarily, even if it doesn't have a door? Or may they utilize a curtain, privacy screen, or something similar that confers at least some measure of privacy? Does that help the state?
Dr. Kasoy, this ties to quarantine and spacing, correct? So
Yeah.
It's the same, the 6 feet, and doors are not necessarily required.
Yeah, I mean, from an infection control point of view, right? If you want to move someone who is not symptomatic, right, so that someone who is symptomatic has a room, just from a medical point of view, it makes sense for this individual to share the common space, right? It makes sort of cordon off part of the common space into a sleeping area with some way to maintain privacy. Medically, that makes sense. I guess I would defer to you, Brett, or you, Moira, about how that fits into the overall regulatory piece.
Yeah, I think we've had some providers indicate difficulties with roommate situations and during this crisis, and folks refusing to isolate or refusing to leave if they're well and their roommate is positive or symptomatic. But if this solution is physically available to a provider, and a privacy screen could be erected, I would kind of write it up again and send it to the field office. I imagine that we would be supportive of it from the standpoint, as Dr. Kasoy was indicating, from a medical infection control point of view. The key piece, I would say, would be the comfort level of the resident and their willingness to do that. And other than that, I think I don't see a downside.
Thank you, Brett. I also want to piggyback on what Brett was just saying, just in regard to any concepts and ideas that you have for your programs to be able to either maintain staff, work differently within your agency. I know a couple of agencies have talked about moving around some of their community residences and renting a larger space so that they could work within the staff that they had. We've had a number of requests. We certainly want to be able to see those. We'll have a one-day turnaround to you. Please bring that to your field office. We'll work to get whatever is reasonable agreed to with you. We recognize that this is a challenging time, and we all need to be flexible in what we can do. So I just want that out there. If you have an idea, please send it to your field office and or up to us. We will work with the field office. We will work with you and get you what you need to the best of our ability.
Okay. Another question we have. So someone chatted in, clients have to be in program 11 of 21 days for billing. So if they're quarantining with family, how does that work? And is it expected that you would provide services through telehealth while they are with family?
Right. Because an individual is not in the program, as long as they are still a resident in that program, whether they're with family or not, they're still a resident of that program. You haven't discharged them from your program. So again, providing that telehealth in that period of time is reasonable.
And not in another medication.
And they
like
can't be in a hospital, because that's really the key.
Okay. So I have two questions related to staff and quarantining and testing positive. So here's the first one. If a staff member has a family member that they live with who has tested positive, can the staff member still report to work if they do not have symptoms and they wear a mask?
The answer is yes. They should continue working wearing a mask and check their temperature every 12 hours a day. And as long as they're asymptomatic, they can continue to work. They should wear a mask.
Okay. So here's another additional question with a little nuance.
They live with that family member, right? If they have a family member who doesn't live with them, then that's not a direct contact, right? So if they're living with a family member who's tested positive, then they should wear a mask at work and provided they're asymptomatic.
Great. So to follow that up, what if a staff member has not tested positive, but they do have they are showing 1 to 2 symptoms? What's the approach for that?
They should not come to work.
Got it.
They should not come to work. They can call their local health department and see if testing is available for them.
Okay, thank you.
Okay.
And I think someone is asking, there was a little confusion with, someone's asking, has the guidance changed from quarantining from 14 to 7 days? Could you clarify?
A+ to the person who caught that. Yes, that was a change from the health department. So in the written guidance on the website, it says 14 days. But since that got approved and posted, the Department of Health changed that. So now it's for a healthcare worker, and your folks are, you're all healthcare workers. It's being 7 days since the first symptom, and 3 days without having any symptoms, without using like Tylenol or whatever to bring down your fever, whichever one is longest. Now, for non-healthcare workers, still 14 days. That hasn't changed.
Got it. Okay, that's very helpful clarification. And kudos to the participant who chatted that in and caught that. So I think with that, we are just about at 3 o'clock. I wanted to ask the state if they had any other items they want to share or offer before we close our webinar this afternoon.
No, I just really want to say thank you again, but I also want to say, we really mean what we're saying. If you have ideas and concepts to be able to make the changes necessary in your program, please talk to your field office and forward them any ideas. We will try our best to be as flexible as possible.
Great. Well, thank you, everyone, for joining us today. And as I said, we'll be sharing the slides and the recording soon. And MCTAC is working to get all your questions sent to the state shortly as well. Hope everyone stays healthy and well. Take care.
Thank you.
Bye-bye now.